Now we're going to cover COPD. Two diseases that fall under this umbrella are emphysema and chronic bronchitis. COPD. So chronic bronchitis, what is it? Well, inflammation occurs and there's an increased mucus production. There's also some structural changes. Now, when we talked about asthma, we talked about how that's reversible. Now, you'll look at chronic bronchitis and say, oh, look, symptoms look a little similar, right? Well, yeah, they are. Biggest difference is these changes are not reversible. Whereas asthma, when you don't have symptoms, pretty much your airways get pretty much back to normal. Chronic bronchitis doesn't. So you have the mucus production, inflammation, structure changes. Okay. Now emphysema is a little different. Still under the umbrella of COPD, which is chronic obstructive pulmonary disease. But what happens here, there's destruction and enlargement of the air sacs. The air sacs, the alveoli that are at the end of the bronchiole. This is where our gas exchange occurs. So if we destroy them, we lose space and we lose opportunity for gas exchange. So the patient can't produce the oxygen that they need. Risk factors for developing these. Number one risk factor, smoking. I can't say enough there, guys. Smoking. Now there is some hereditary focus in here. There is some genetics. If you have alpha antitrypsin deficiency, AAT deficiency, that's genetic. In that you can develop COPD as a result of that. But most of our cases are related to smoking. Okay? Occupational, again, hazards can play into it, air pollution, infection, but number one, overall, smoking. So what happens with this? Well, it develops slowly. It occurs over a period of time. Sometimes what they'll originally complain of, and when they look back at their history, they have a chronic intermittent cough. And your hope is that you can get them to be seen at that point so you can prevent some of those structural changes. But most likely, that's not when they're going to go seek out treatment. Dyspnea is progressive, usually occurs with exertion, and they may feel like they just can't take that deep breath anymore. And eventually, it interferes with their ADLs. That round of golf that used to be an easy walk for them is no longer that easy walk for them. Now, when it's advanced, when COPD advances to the later stages, we know frequent experiences. They have weight loss despite eating what they normally ate. Fatigue, coughing, prolonged expiratory respiratory phase, wheezing, adventitious breath sounds, right? Decreased breath sounds. Long-term complication, develop a barrel chest. They have to change their position to be in a tripod. You may note use of accessory muscles, hypoxemia. They may develop this bluish-reddish color to their skin. They start to retain CO2. So then, you see their arterial blood gas is kind of taking on a 50-50 where they're pretty much even with O2, PO2, and CO2. They may eventually develop edema in their ankles, secondary to right-sided heart failure involvement. And this is what we call cor pulmonale. And that's all later stages, okay? So what happens? You have an acute event. You have an exacerbation. What are we going to do? What are we going to talk about? We're going to look at increased dyspnea. What's going on here? How much are they breathing? How fast? What increases the shortness of breath? And then we're going to get into gross things. What does their sputum look like? How much are they producing? What color is it? Does it have an odor? Are they fatigued? Unable to sleep? Confusion? Unable to do the activities that they used to be able to do? Increased wheezing. They may or may not have a fever. It depends on what's going on. Now, one thing to note is if we see a COPD patient coming frequently back through our doors in the hospital, that usually means that there's going to be a poor outcome for this individual, that they're reaching the point where they're disease is taking control of them versus them controlling the disease. Usual treatment focuses on bronchodilators, supplemental oxygen, short-acting anticholinergics, corticosteroids, and in extreme situations they may be put on something like CPAP or BiPAP. Now remember, if patients have frequent exacerbations, they are definitely at risk for respiratory failure, so we're always watching out for that. We do know that we want to put these patients on a beta-adrenergic blocker like an atenolol because they do note that it does improve survival rate. And remember, these patients will retain CO2, so we have to carefully monitor anytime they're on oxygen, whether it's during surgery or postoperatively, because CO2 can sometimes, if they're retaining CO2, I've had this happen a couple times, especially to newer nurses, where they think the patient's resting comfortably, but in essence, their CO2 has risen so high that it's actually a decrease in alertness. They're not resting comfortably. The CO2 is driving that. Remember, if they have abdominal surgery, it can lead to more or increased ineffective ventilation, because think about, especially like, or any of them really, but let's talk about the emphysemic patient. You got abdominal surgery and you're already dealing with a lung that is not at its best capacity. And now you have abdominal surgery and the patient's doesn't want to take good deep breaths anymore. And so you're decreasing the capacity even more so that can progress into respiratory failure. So these patients all have little idiosyncrasies that we have to watch out for. Okay, so spirometry. This will help confirm airflow obstruction. This is a PFT, pulmonary function test. They go down to the lab, they get it done. Okay, respiratory therapy will do this. Chest x-rays. Usual findings, we're going to see a flat diaphragm or hyperinflated lungs. Remember we talked about genetics. You may go for the antitrypsin levels. Arterial blood gases will be done on most of these patients. Now, we do talk about a 6-minute walk test. Now, what this will determine is if the patient needs oxygen at home. Okay? This is they're taxing their body by walking, and then we've got a continuous O2 sat monitor on them, and we're seeing how they do. If we see the sats drop below 90, hover 85 or so, then they're going to qualify for oxygen at home. Then there's some testing or like written testing you can do, like a COPD assessment or a Bode index to determine the severity of the disease. So what are we going to do for our patients? What kind of things are we going to teach them about? Well, if they're a smoker, we want them to quit. Like if we send them to pulmonary rehab, I know the pulmonary rehab where I had worked, if they did not quit smoking, they would not be allowed in the program. They had to show that they had quit. Because what's the use of rehabbing them if they're going to continue to use something that's going to hinder their breathing? Drug therapy is focusing on reducing symptoms, and again, they're going to be on bronchodilators, long-acting bronchodilators, inhaled corticosteroids, long-acting bronchodilators. O2 therapy, usually the goal is to maintain an O2 sat greater than 90%. Always want to start with the lowest liter flow to maintain that. We don't want to put these patients on high flow oxygen if we can avoid it. We always start low and taper up. We'll also teach them about breathing. How can they breathe more effectively? Well, one thing they can do is pursed lip breathing, which is prolongs exhalation. It prevents air trapping and bronchial collapse. It can also help them be able to do certain activities because they're kind of controlling their breathing as they're doing the activity. We can also teach them about diaphragmatic breathing. They can also use airway clearance devices or techniques, teaching them how to effectively cough. Maybe they're going to get chest physiotherapy, where you're cupping and clapping on their chest, which is postural drainage, which helps move the secretions out so they can cough these things up, because the secretions are pretty thick and sometimes it's hard for them to cough them up. Airway clearance devices can also be used. Nutrition plays a big part in it, because remember, they're working hard to breathe, so they're going to burn calories off. This is important. Then we're going to increase fluid intake as well. Conserve energy 30 minutes prior to meal, or use a bronchodilator prior to meal, because even just the activity of eating can take a lot out of them. We may have them on like liquid supplements, especially if they're having trouble breathing, because they can get increased calories by doing this, and it will help them breathe better. And it's not as taxing as chewing and that kind of stuff. In some cases, they may qualify for lung volume reduction surgery. In some cases. All right, so we talked about smoking cessation, and we'd love to early diagnosis. So, for instance, if you are a nurse practitioner or you're taking care of a patient that's a chronic smoker, get a good history. Do they develop a cough? Do they have those kind of things going on? Is there a family history of COPD? So we're looking for that genetic link. Make sure they know their meds. Again, what a bronchodilator is, what a corticosteroid is, how to use those inhaled corticosteroids. Do they know to rinse out after using the inhaled corticosteroids? Rinse that mouth out. How can they effectively clear their airway? How do they cough? Do they have a good cough? May refer them to pulmonary rehab as well. We may have to talk to them about altering sexual activity, different positions to conserve energy. And the big thing with COPD is trying to help them maintain their quality of life. That's what we want. That's our ultimate goal for these patients.